the University of the West Indies, where she received her MBBS and Diploma in Child Health, and then went on to the University of London, where she received her MSc in Dermatology. She has worked as a pediatric resident at the Bustamante Hospital for Children and also at the Kids Clinic, and then she was a dermatology resident at the University Hospital of the West Indies, and private practice, she's a dermatologist at Apex Medical Center. Her academic affiliations, she's a member of the Caribbean Dermatology Association, Secretary of Dermatology Association of Jamaica, Fellow American Academy of Dermatology, and Associate Member, Pediatric Association of Jamaica. Well, I mention these because we know that when you're involved in these associations, you do a lot of work. Right? So she also practices at the Apex Malines and Portmore Center and is co-founder of Apex Healthcare Associates with Dr. Patricia Yap. We invite her to come to the podium and speak on effective management of atopic eczema. Dr. Ffrench.
Good morning, everyone. Well, thanks for coming, and thanks to the General Practitioners Association for inviting me. What I find with atopic eczema, it is largely a childhood disease, and as a dermatologist, I'm not really the first person that is seeing these children with it. It's usually the GPs and the pediatricians. So by the end of this, I hope you'll have a better understanding and a better working knowledge of how to approach the management of atopic dermatitis. Scabies. I put on scabies because sometimes in the early presentations of scabies, you're not going to see the typical things in the soles of the foot and along the fingers, especially in the babies. And it commonly just presents as fine little papules on the trunk. I guess you must always have a high index of suspicion, especially in infants, because even using 0.5% hydrocortisone I've seen babies come 2-3 months old and they will have this florid, difficult to manage case of scabies because it was initially diagnosed as an eczema. So always bear scabies in mind and probably if there's a family history of anybody else at home who's itching, so it can be treated early. Slides. Another common thing that I commonly see misdiagnosed as atopic eczema, particularly in the face, is plain warts. Because in the early stages, plain warts look very innocuous, and it's only when the steroids are used to treat eczema that you see them spreading quite quickly all over the face. All right, so the fundamentals of treatment. What you'll find is that if we can control the atopic dermatitis early, there's a greater likelihood that these children will go into remission. If it's allowed to linger and they have frequent flares up, they're less likely to go into remission. So the aim of management should be to decrease the severity and to decrease the frequency of flare-up of atopic eczema. So how do we approach treatment? Well, the first thing is that we assess the severity of the disease. So you get an idea of whether this is a mild case, moderate to mild, moderate or severe case of atopic eczema. And I'll go through these in turn. We repair the barrier function. We stop the itching. We treat colonization or infections. We control the inflammation and patient education. Now, atopic eczema takes plenty talking because it's sort of difficult to maintain a routine. Probably giving medication once a day is a far easier routine to manage than moisturizing twice daily, putting on your creams on top, giving oral antihistamines. So it takes a lot of hand-holding on the part to educate them as to why you're doing this, and including showing the patients how things are best done. I should finish that now. the first thing we normally do is assess the severity. Now, I'm just going to quickly go through SCORAD. This is not something that we'd use in clinical practice. This is often used for clinical studies for efficacy of management. But it's good in that it gives you an idea of what are the things that you'd look out for. So there are 3 areas that are assessed and each is given a score: the area, the intensity, and the subjective symptoms. Okay, thanks. So as you do in burns, you can get an idea of the area and use a rule of 9s to calculate how much is involved. And then you'd add up each score depending on what part of the skin is involved, and you get a score of up to a maximum of 100, which is total body involvement. Okay, for intensity, basically you're looking on your clinical assessment of the severity of redness, if there's swelling of the skin, crusting, lichenification, scratch marks, and dryness. And you give an assessment of if there's none, mild, moderate, or severe. Okay, and this gives a maximum intensity score of 18. And then there is the subjective symptoms, but this is based on the patient's or the caregiver's assessment of how severe scratching is or how much sleep they lose as a result of their itching. So as I said, this is not something we do routinely in daily practice, but it gives an idea of how to approach assessment. And they have this nice fancy chart and everything is scored and you come up with a final score and it's used, as I said, as an assessment of effectiveness. Okay. All right, so in daily practice, basically, you can simplify it a lot. You have to examine the whole skin and you decide whether, okay, is the patient clear? Is there only mild dryness with or without minimal itching? And that would fall under the category of mild. Moderate you'd see localized areas of inflammation, as we've probably seen when I showed you those flexural areas. And with frequent itching with or without excoriations and skin thickening. And of course severe, where there's widespread involvement of skin. The only thing I really wanted to emphasize on this slide is we can take a pyramid approach where the base of the pyramid reflects the most important aspect of management. And in this case, it's the use of emollients. Okay. Now, if you think back to the pathogenesis, it's the impaired barrier function that is the start of everything. So if you take nothing else, please take home emollients and moisturizing is the first line of treatment, and before you do anything else, emollients, emollients, emollients. So basically the emollients are what will repair the barrier of the skin. Emollients are really a mixture of oils with water. So the oil would be the equivalent of trying to replace your lipid layer, and the water to replace the the water content of your cells. So just by moisturizing, you'll improve the barrier function of the skin, and I promise you that by keeping up moisturizing, you'll reduce the number of flare-ups and the severity of flare-ups of your children with atopic eczema, and reduce the need for steroids. But this has to be something continual, and it is very difficult to get patients to moisturize every day. The soaps that we use, the emulsifying ointment, the Dove, those are also good options because they moisturize the skin while cleaning the skin. So you would advise to use the bland soaps, which add moisture to the skin, and not the more drying soaps which cut the oil from the skin. Emollients are also important to manage itching. Dry skin is itchy. So you may start with just a bit of dry skin, and the patient starts to scratch, and that just drives the whole inflammatory process. And if you're not controlling the itching, the symptoms get worse. The worse the symptoms get, the more they scratch. So it is important to break the itch-scratch cycle. So again, moisturize, moisturize, moisturize. If we need to, especially if they are not sleeping well, you can add oral antihistamines. I tend to use the sedating antihistamines, the DPH or the histolinanite, and one of the non-sedating ones in the day. Reduce colonization of Staph aureus. You probably would not need to do this for patients who have mild eczema. You would consider it for those patients who would say, oh, I use it, it clears quickly, but as soon as I stop, the eczema comes back. You sort of have to think a little further, is there another trigger? So those are the patients you could consider starting regimes which would reduce staph colonization. So we have a few antibacterial soaps available on the market. What is commonly used now is bleach baths twice a week, and this really does reduce the staph load on the skin. Of course, you'd need oral antibiotics if there's obvious sign of infection. And for those that you probably do a skin swab or a nasal swab and it does show that they are staph carriers, you can use intranasal mupirocin twice daily for about a week to reduce the load. Now, control of inflammation. Basically, topical steroids are the mainstay. The topical calcineurin inhibitors have been introduced recently, and they are effective, but they are expensive, and they are not as, they do not work as quickly to control the inflammation. This is your Protopic and your Elidel. So they are very useful in certain areas, certainly eyelid, skin, certainly in children where you want to use it to cut down the use of steroids, but the response to it is much slower. So that's something that has to be explained to the parent because everybody wants it to be fixed very, very quickly. Oral steroids, uncommonly used, but they do have their place in the very, very severe cases. What caused a lot of confusion is, okay, which topical steroid to use, how much do I use, where to use what, and it does take a bit of juggling. But what I would advise is that you get very comfortable with about 4 or 5 steroids, and you know that you have your hydrocortisone for your mild, and you can use class 2 or class 3 for your mild to moderate. If you are considering using clobetasol, that patient should probably be referred. So I'd suggest you get comfortable with 2 or 3 in each class of drug and use appropriately. Now to give definitive instructions on how to use, how long to use, it does take a bit of juggling. So I cannot give you very specific things. I can give you some advice on some of the approaches I have taken. If I see somebody with mild or say moderately severe eczema, I'll start them off high. I'll start them off with a bentonite to get that quick response, and by the second week drop to a lower grade once you're getting that control. In terms of how much to use, there's this dosage called the FTU, or the fingertip unit, but to say that I go and say, okay, 10 fingertips are what you're using a week, that's really not practical. It's not going to happen. What you have to have an idea of is that 2 fingertips is equivalent to about 10 grams. 1 fingertip is more than adequate to cover an adult's hand, front and back. Okay? So generally speaking, if I'm dispensing to a child, I'm not going to dispense more than about 15 grams because I would estimate that that should last at least 2 to 3 weeks of continuous use. And likewise for an adult, that would probably go to about 30 grams. There has also been a new approach to replace the old approach to treatment where typically, if we get a flare-up, we use a steroid, calm it down. If we get a flare-up again, we use a steroid and calm it down. If you get a flare-up, you use a steroid and calm it down. But there's a new, which is what we refer to as a proactive treatment, where it's suggested that we use topical steroids continuously to control the flare-up, followed by intermittent use to prevent further flares. Okay, so studies have been done using fluticasone, which is Cutivate, and what they're found is that using Cutivate twice weekly for up to 6 months one, does not produce any significant side effects, and two, cuts down on the frequency of the flare-up. Similar studies have also been done for Elidel. So in terms of applying this to our patients, what I would suggest is that we use medications continuously till it's clear, along with your emollients, because that's the mainstay. And if you know that the patient has hot spots, whether it's the knee flexures, the elbow flexures, twice weekly for about a month, you would use one of the lower strength steroids. Cutibate in this, as I said, but I figure we could also extrapolate to use even milder, whether hydrocortisone or Umavate, if you so desire. Okay. So this is just an article which has reference. The calcineurin inhibitors, the Protopic and the Elidel, as I said, is indicated for mild to moderate, but you're not going to get the quick response. The drawback for these is Elidel is about $2,000 a tube. So it would be sort of difficult to use, and that's a 15-gram tube. So, and the time with which you'd use it for would be much longer than, say, using a steroid. So how I use this, as I say, is probably as the twice weekly to reduce the number of flares, or in very sensitive areas like the eyelid skin. Systemic steroids, as I said, used for severe chronic atopic eczema. The problem with using systemic steroids is that you get very good response, but once you stop, a reflare. Other treatments. Well, we don't really use immunosuppressant therapy here and phototherapy. We do occasionally have to use occlusive wet wraps. So this we often use in a hospital setting. That little one that I showed earlier, she was referred for admission. And what wet wraps entail is using diluted steroids to cover the entire skin, wrapping the body with bandages, wetting the bandages, and then putting another dry layer of bandages over it. So what this allows is to use a lower strength of steroid under occlusion, which will improve the penetration of the steroid into the skin, as well as cool the skin from using the wetting of the bandages. And it also prevents the itching. But this is not something that is commonly used here outside of hospital. So in conclusion, atopic dermatitis is a very common problem. We need to establish a correct diagnosis and determine its severity to then decide how best to treat it. In many cases, the treatment is an art. That's what I mean about the juggling. But it must be based on a good understanding of the pathophysiology of the disease. And we still have a lot to learn about atopic dermatitis. Thank you.